an STI clinic.
Good afternoon. As Dr. Belcher mentioned, I'm an MPH candidate at UC Berkeley, and this summer I had the pleasure of working with Dr. Geetanjali Chander, who's an internist at Johns Hopkins. We chose to study factors associated with alcohol use disorder among women attending an STI clinic. I have nothing to disclose. To start with a little bit of background, according to the National Survey on Drug Use and Health, 15.1 million adults over the age of 18 have an alcohol use disorder, and that ends up being 5.3 million women, which is about 4.2% of this age group. It ends up resulting in 5.9% of all global deaths and 4% of all women's deaths. 3.3 million deaths are attributable to alcohol consumption, and it's contributed to over 200 diseases and health conditions. Of these are included alcohol use disorders. It's 5.1% of the burden of disease and injury worldwide, which contributes to 139 disability-adjusted life years, or DALYs. It's the fifth leading risk factor for premature death and disability, but the first for ages 15 through 19. And lastly, 25% of deaths are alcohol attributable of people between 20 to 39 years. Alcohol use disorder is becoming increasingly pervasive, but as it does, we tend to understand the comorbidities that are associated with it. Of these are mental health disorders. 1 in 12 adults in the U.S. have an alcohol use disorder. 1 in 4 suffer with binge drinking, and 1 in 10 use illicit drugs. 1 in 5 adults in the U.S. have a mental health disorder, and that ends up being 7.7 million people with both. About 80% of individuals with alcohol use disorder complain of depressive symptoms, and a third of those meet the criteria for a true major depressive episode. My study takes place in Baltimore, which has an 18% rate of excessive drinking. Excessive drinking is different from an alcohol use disorder specifically, but it's categorized by people who reported binge drinking and excessive drinking, which is drinking over 3 glasses in one sitting for women and 4 for men, and more than 1 per day on average. There are associations between excessive drinking and having a true alcohol use disorder, but Baltimore's rate of 18% is still about 3 times as high as the national average. So it makes this city specifically very concerning, and then our population in general. It's a large issue, and we need to be able to fully assess it and the different comorbidities associated with it to be able to truly work on interventions that are more successful in healing long-term rather than just getting rid of symptoms. Which leads us to our research question. So we wanted to study which comorbidities are associated with alcohol use disorders in a particular set of women attending STI clinics in Baltimore, Maryland. So my data came from a baseline data set from a clinical trial using a computer-based intervention, which was named PD. And it was collected in 2 Baltimore STI clinics. And then I used data for statistical analysis to collect demographic information, to do chi-square tests for association, and multivariable logistic regressions, English. A few demographic characteristics. Our age range was from 18 to 66 with a mean of 34. Which is actually very close to the national average of women with alcohol use disorders. It was 88% Black, 96% not Hispanic. The majority of women had stable housing and had at least a high school education or more. And then about half of our population made between $0 and $5,000 per year. The other half made between $5,000 and anything above that. The construct we studied were the alcohol use disorder. In order to measure that, we used the Diagnostic and Statistical Manual, Volume 4, the mini interview. For post-traumatic post-traumatic stress disorder, we used the primary care PTSD, which was a short version of 4 questions. For general anxiety disorder, we used a 7-question set. For major depressive disorder, we used the Patient Health Questionnaire 9. For unwanted sexual experiences, we used the COS Sexual Experience Survey. And for drug abuse, we used the National Institute on Drug Abuse Assist Questionnaire. For diagnosis, there is an updated version of the DSM, which is 5, but the differences are pretty small. DSM-4, which is what I used, differentiated between alcohol abuse and alcohol dependence. So the first 4 set of questions tested for alcohol abuse, and if you marked 1 or more, you qualified as having an abuse disorder. The second set of 7 questions tested for dependence, and so if you had 3 or more, you qualified as being dependent. In DSM-5, they combined all 11 questions into 1 set, so if you had 4 or more, you had a moderate to severe alcohol use disorder. Lastly, they took out 1 question that asked about being arrested due to your alcohol use, and then added a question based on cravings, like what do you wanted to drink so badly you couldn't think of anything else. In the studies I've read comparing the two, it's been pretty consistent. There hasn't been too much of a difference in women and men who may have qualified as having abuse or dependence versus those who qualified as having an alcohol use disorder. So in our population, we found a rate of alcohol use disorder of 67.9%. Which is 13.5 times the national average, which is only 5% among women. So it's pretty concerning, and it led us to decide to want to characterize the population further to understand what else was going on to try and see why the rates were so high. So first, we studied mental illness individually. We studied depression, generalized anxiety disorder, and PTSD separately using chi-squared analyses, and each one were statistically significant with p-values less than 0.001. And then I put them in a multivariate regression. When I did so, as you all can see, the p-value is very high for generalized anxiety disorder, so it was no longer statistically significant. I think it's because all 3 are very correlated. Most women who had 1 had more than 1. I think among women with depression, only 12% only had depression, and the other 88% had something else with it. So that's definitely something to take into consideration. But you can already see in these preliminary findings that the rates of women with alcohol use disorder that also had a mental illness were almost twice as high as the women without alcohol use disorder. So we then decided to create a count variable to test how many women had no mental illnesses, 1, 2, or 3 of the ones I mentioned before. And you'll see women with alcohol use disorders were significantly more likely to have 2 or more mental illnesses, especially if you look at women with all 3 concurrently. It was 14.9% for women without alcohol use disorders, whereas it was 33% for women with alcohol use disorders. We then studied drug use. We studied individually a set of 6 drugs and then decided to make a similar count variable to the one that we used for mental health disorders. We decided to combine anything above 2 to a 2 and above rate. And we saw that there wasn't much significance in women who used only 1 drug, but between none and 2 and above, it was vastly different for women with alcohol use disorders and without. One thing to note is that marijuana is incredibly pervasive in this population. Among women who used only 1 drug, 87% used marijuana. So we think that might be why there wasn't very significant, but there was a very high prevalence of multiple drug use among women with alcohol use disorders. Lastly, we studied unwanted sexual experiences, and as you all can see, there's a very high rate of sexual assault in this population. The national lifetime rate is around 20%, and you can see in this population, it's about 65. It's also important to note that in this total population, 36.5% of women have survived rape. So it's very high in general, and 43.6% of women with alcohol use disorder have survived rape. So these are you can see similar trends in unwanted sexual experiences, which leads us to our multivariate regression. So we decided to test all of these and controlled for age and education to see what was really going on as far as looking at odds ratios and see what led to a higher chance of having an alcohol use disorder. Most were statistically significant. Coercion and sexual contact were not, but they were pretty close. And like I said, with one drug use, it was probably because of that marijuana use. But you'll see that it's very common for women who have alcohol use disorders to also suffer from mental health disorders, drug use, and unwanted sexual experiences. So overall, we found that women with alcohol use disorders are significantly more likely to also suffer from PTSD, generalized anxiety disorder, and major depressive disorder, as well as 2 or 3 at the same time. And they're also significantly more likely to use 2 or more drugs, as well as to have suffered from more unwanted sexual experiences than those without alcohol use disorder. This is a very understudied population. Most studies about alcohol use disorder are about men because men have higher rates in general, and the ones that are specific to women tend to study pregnancies and fetal alcohol syndrome, or will only study 1 or 2 comorbidities, whereas this provided us a very comprehensive data set that studied a lot of different comorbidities and allowed us to see the interactions between them. Some limitations were that it was cross-sectional, so we don't have any way of determining causality. And it was a very unique population, but I think that makes it very important to study a population with a prevalence this high in order to understand how comorbidities end up playing out with alcohol use disorder in order to develop more long-term lasting interventions. Next steps, I would like to see a longitudinal study to see if women had adverse childhood experiences or sort of a what came first, the chicken or the egg type thing with unwanted sexual experiences, or if it was drinking that led to risky sexual behavior, which led to mental health disorders and things like that. But thank you so much to my mentor, Dr. Chander, Dr. Belcher, Dr. Van Eck for all of her help with my presentation, Johns Hopkins, the Ferguson RISE Fellowship, Kennedy Krieger Institute, and CDC.
So, any questions on the CDC side?
I think we're okay, thank you.
Thank you. Any questions on our side? On Baltimore side? Oh, you know, I have a question. So I'm just wondering, were you surprised at what you found? Were you surprised at the comorbidities?
I wasn't. I was surprised at the rates, but I think after looking at how high the rate of alcohol use disorder was, it was pretty intuitive to see that women were more likely to suffer from a lot of comorbidities. But it was just very interesting for me to see how high exactly they were, because I did expect that I would see women suffering from an alcohol use disorder to also maybe suffer from depression or anxiety, and it might have been some sort of self-medication type of situation. But I was surprised to see how high it was, even with the women without alcohol use disorder.
I wonder if they're recommending PrEP for this population.
I do wonder, actually, because they were visiting an STI clinic, I wonder.
Probably so, right? And so what might you suggest, or in terms of your study, what differently might you do or recommend for the STI clinic?
Oh, that's hard. I think definitely just making sure at any type of medical facility, whether you're going for just STI testing or treatment or whatever it may be, that they do end up asking more about what they might also be suffering with, because if they are suffering from an alcohol use disorder or anxiety, depression, or other substance uses, it may not be being treated. They may not even realize that they have it. So I think it's important for any doctor that sees them to sort of try and assess that and be able to direct them to the resources that would be helpful.
Screen for that, or maybe even provide integrated mental health services.
Exactly. And like I was talking to Dr. Van Eck, with these tests, it sort of screens for symptoms, but I think it would have been helpful to have more of a semi-structured interview to really make a true diagnosis of if they did have these disorders.
Right. So I think we're talking about kind of interdisciplinary work. And so maybe this is something that needs, we've talked about it in pediatrics and having mental health services, but also for women's health and STIs because of this kind of high risk that might be walking through the door, that maybe you have a social worker or a psychologist that's part of your team.
Definitely.
Very good. Thank you.